All right, welcome back. This is kind of a first time that we've ever done this segment, which is a follow-up, and I think this is a brilliant idea from Mike Bruner, who's joining us again, is to kind of follow up to a PCBH Corner that we just put out. And I don't know, maybe we'll have to come up like with a good name for it, like a response to the PCBH Corner, whatever it is, but just thoughts and ideas to have a conversation. So Mike, we just put out this obviously PCBH Corner on, how to do an intervention without doing an intervention. Where was your mind going? Thoughts, ideas? Where were you going there?
I mean, first off, I just want to give you and Bridget kudos. Like, that was dynamite. I just loved it. Would have loved to have seen that second half, and we'll look forward to seeing the next one. Yeah, you guys just really had my mind running as you were going through that. And it got me thinking about some of the challenges that all of us have, but especially like newer BHCs, in their efforts to adhere to the PCBH model, how I think that they might even kind of like derail visits a little bit, So what it got me thinking about was you were talking about kind of doing an intervention without doing an intervention, kind of being subtle and implicit, and kind of doing things without actually labeling those things, right? And so it got me thinking a lot about when patients are kind of giving us hints as to what they want. For example, I just need someone to talk to, right? Or I need therapy, you can, I'm going to be kind of bold with this and you can tell me if you disagree, but I don't know that there's really any good way to tell a patient, well, actually, I'm not a therapist. I don't know if there's any actively helpful way to tell someone, well, we're not really going to talk, we're not just going to talk. We're going to do this, we're going to do that. I just feel like that fits so well into a lot of the things you all were saying in terms of keeping your ear open to where the patient is at, what they need. They're telling you right there that they don't want what you're about to tell them you are.
Mike, and again, this is why we're going to have to make this maybe a regular thing, because that's a brilliant thing that I don't think Bridget and I were even thinking about within shooting that type of video. And spot on, this idea, because as soon as someone says, it's like, well, I'm looking for therapy, or I just want to talk. And then, as you said, people that maybe they see PCBH in a certain way, it's like, well, that's not what I do, right? Like I was told, like, I'm not a therapist. I don't do these things. Right. And how that response, like, yeah, that's going to be kind of a very disengaging conversation if it's tried to be done in a very overt way.
Exactly. And I would say at best, if you are just highly skilled and amazing, you're going to come out of that discussion sort of neutral. Like, if you've just nailed it, you haven't helped yourself, but you've prevented damage. But how much time did that take you in the context of you're trying to do that 30-minute visit? If you're trying to adhere to the model, what did you spend? Like 10% of your visit getting there and really getting nothing out of it, No,
I love it, man. I think it's a really great observation, and something that, I don't know, my mind goes a lot of ways. I keep going back to this one patient. This is kind of the opposite end of the spectrum that I saw last week. It was actually an OB pathway visit. 18-year-old went through horrific trauma and different things. And as soon as I walked into the room and I introduced myself as a psychologist, we're wearing masks, but I could see in her eyes. She was like, nope, not going to have this. So what's interesting, right? Because I think in those moments, and bring me back here because I'm going off on a tangent.
You're good.
I think in those moments, what happens a lot of times with BHCs is like, oh, this patient's not picking up what I'm going to say. I'm going to leave this room. Like, I'm going to get out of here. Like, it's like, clearly they don't want to interact with me right now. Clearly they don't want this. Like, I'm going to leave. And my mind even went there. It's like, okay, this is going to be like a 7-minute visit. Like, she's going to boot me out of this thing. And it turned into a 40-minute visit. That was one of the most healing visits that, at least for me, it reminded me of my value, my why. And still, even at the end, she said, she asked me, she goes, "Are you a therapist?" And I was like, yeah, that's an interesting question. I'm really curious about, why your mind is curious about that. We had a good conversation, but basically she couldn't stand therapists. in a way. And so we got to have a really, really good conversation about like what we do, and then also like our approach to different things. But going back to the original response to that, I think there's so many different things that our minds just go to. And like when you see someone like, oh no, like you could tell you said psychologist, I don't want to talk to a psychologist, and still how to engage that individual and that human.
Right. Well, and I think the interesting thing about that example is that the question did eventually come up, but at that point it was almost a moot point, right? Because regardless of the words that come out of your mouth, she has already experienced what you are without you ever saying what you were or were not, right? So there's really, again, there was no way to have that discussion ahead of time in a way that was probably going to be helpful. So instead, you just were who you were for 40 minutes. And now, sure, fine. Now let's put some words onto it. You know, but that's all then going to happen in the context of her real life experience with you. Right.
Dude, exactly. And what my mind is, who the hell knows, right? I have no idea. We're just making stuff up right now. My mind says the reason why she asked it at the end of the visit, one, because there was trust there, and she was like, oh, this is different. Like this is a little bit, this engagement, it was more human, it was more curious, it wasn't clinical, it wasn't trying to pathologize someone. 100%.
Implicit in the question was the suggestion that this was not what I was expecting, right?
Correct.
Because she wouldn't have asked the question if it was exactly what she expected a therapist to be, you know? So it just got me thinking about when we're doing this stuff with patients, when we're doing an intervention, if a patient says, I just need someone to talk to, saying, yes, cool, that's what we'll do, or, oh, wait, that's not what I do. Either way, not productive, not helpful. Just roll with it, do what you do. And here's the great thing. If you're skilled at doing these implicit interventions, these subtle interventions, you still get to do what you feel you need to do. And the patient feels like they got exactly what they needed. They got to talk to somebody, and no one tried to tell them that that wasn't what they needed.
Mike, and it goes back to what we were having the conversation on a little bit earlier, where understanding philosophy and principles and these foundations, regardless if it's like, we talked about it more in the video about behaviorism and, relational frame and theory and different things like that. But even just within like understanding the philosophy and principles of PCBH and of primary care, all those things that you just said comes down to, it's like, hey, I'm highly skilled, not because I know a million different interventions. I'm highly skilled because I know philosophy and the underpinnings, the foundations of what I'm doing.
Exactly. So those were my thoughts. So now I'm going to follow this up with a question, and I want to see where your mind goes with this. So I, in my mind, kind of put this in the context of especially new BHCs who are just trying to figure all of this stuff out and be the best BHC they can be, follow the model. So what we're talking about is really awesome. If you can get to this point and do this, I think you're almost guaranteed to live like the true role of a BHC that way. That being said, I do wonder, does this make some of the other things that new BHCs are trying to do, for example, have good time management, have structure in their visits, follow up in a way that's very much like, okay, traditionally, right? It's like we came up with our action plan, follow-up's going to come, and it's going to be like, okay, how did that action plan go? Right? That's what we teach our new BHCs to do. If you're doing this though, how do you do that?
Yeah, I think, my mind goes a different way. It's a brilliant question. And honestly, I think it really reinforces the stuff that you're doing at Health Source, as far as having practicum students, come in, and then also having, fellowship, for postdoc fellows to come through. I think that's the thing that we probably need to embrace what you just said more actually overtly, in a sense of like, this is a lot of training. Like this takes a huge skill set to be able to do. And I think the one thing that we've done, and there's a reason for it, my mind says, the context is like we have a huge provider shortage problem. Yeah. So that basically means like, hey, we got to get a lot of people trained up to be able to go out. The danger in doing that, though, is that we start to skip steps. Like we start to skip steps. It's like, hey, just diagnosis, intervention, and to go from it. So where my mind goes is that us trying to really embrace this, one, having more training programs, and within those training programs, embrace it, that philosophy of learn it, do it well, then you become efficient. It's not you're efficient at the beginning, while you're learning it and you're doing it well. No, 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 no. This is learn
Mhm.
it, you do it well, and then you become efficient. And then I think also sharing our stories, I know how it was for me, and I tell our interns about this regularly throughout the year and our fellows throughout this. Like for the first 6 months of doing my fellowship, where I really felt like I was getting this training, this idea, I felt like I was a terrible provider. I felt like I was a horrible provider. And when you put that in the context of being someone who's being evaluative or evaluated and wanting to do good work, that's a terrible context.
You got it. I mean, my mind was just right there with you. I was thinking, you're always talking about creating a context for XYZ, right? And so I think along with this then is just crucial that we're building a context for our trainees that's okay. Having
Yes.
a 40-minute visit doesn't mean you did a bad job. Is that patient wanting to come back at some point and see you again? You did good. You did good.
What's interesting is that I've had this conversation with some of my interns, like, oh, that visit went like 40, 45 minutes. And I was like, oh, I just had a visit that went 45 minutes. Like, so what do
Right.
let's break this down. And I think that's the thing again. And this is where I wish we almost were like family medicine residencies. I wish we had 3-year training programs within PCBH, because the amount of reps that I think it takes, the amount of love and kindness and support that is needed during those formative years, it's really rare right now. And I think that's the thing for training programs to really try to embrace. One, normalizing this is going to be hard work. It's going to be a lot of upskilling. You're going to feel terrible about the work you're doing, and that is okay.
Right.
We're going to be building on this, and I'll wrap up, and I want to know where your mind's going. I also think us normalizing when you notice, because what starts to happen is like you start to see it, but you don't know what to do with it. Like you're like, oh, I see this right now. I can feel myself trying to intervene in a way I know I shouldn't. And then after the visit, being able to very much critically go back and say, what could I have done different in that visit?
Yeah. And again, making that okay,
Okay.
as a supervisor, having that, fellow or practicum student, whoever, come in and say what you just said, and us being able to say, awesome.
Yes.
You picked up on this in the visit. You noticed this as it was happening. That's amazing.
Mike,
let's talk about that and see what we can do with it.
That got me hyped. That got me hyped right there. Yeah.
Yeah.
Absolutely.
You make it easy, man. That's all I had. I had a couple thoughts. I had a couple questions. So,
I really love this format. And so I think one of the things that we'll try to do is maybe make this more of a regular thing, and even encourage people that are watching this. Like if you, after watching a corner, if there's something, and if Mike posts a video and after watching it, you're like, hey, I have some ideas and stuff, reach out, because I think it would be really good, one, just to talk about it, but it could be really good because if other people are thinking what your mind's thinking, it would be helpful to get some stuff out there.
And it's fun.
That's what I'm saying. I appreciate you, man. Awesome job.
Yeah, and you too. All right. Hang in there.
All right.